experts present.
Vinisha, tomorrow, what time we have the fourth meeting? What time we start?
So tomorrow's meeting will start at Indian time 11 a.m. So I believe it is somewhere around 8 a.m.
7:30.
7:30.
Yes, 7:30. Yeah. So
7:30 in the morning, yes?
yeah. Right. So it would be
Okay.
a 1.5 hour meeting. So it's a close group meeting tomorrow.
Could you kindly send me all the details today?
Sure.
Good. Thank you. So 7:30 a.m. my time tomorrow. Good. Please kindly send me this email, this link, etc., etc. It would be easier because then I just connect with you using this and not speaking through all the emails. Okay. Hello.
Yeah, sure, Professor. We'll be sharing across.
Good. Thank you.
Yeah.
So I put myself on mute for a second.
Yeah, sure.
I'm so sorry. My network just dropped. Am I audible?
Yes, you are.
Yeah. So, Professor, should I send you the link for tomorrow's meeting today late night or maybe tomorrow morning?
Whenever is late night would be great idea. Yes.
Yeah, sure.
The same topic.
Yeah, the same topic, but it would be more of an expert group meeting. So we would
Say
have
again. Would be what?
it would be an expert group meeting, something that we had in Mumbai.
Mm-hmm.
So we have 9 to 10 doctors. So we would have a bit of discussion initially.
Thank you.
Yeah.
One is to one broken into especially. Even though it's a great food, but sometimes I don't think we get the bottle size right. We don't get a 2.75, get a 2.53, 3.54, I think. So the
Hope I'm audible, Doctor. Dr. Ponikowski.
Yes, you are.
Sir, I think we are good to go, sir.
Very good.
Yeah. Vinisha, can we go ahead?
Sure, Rani. Maybe we can start.
Yeah. Good evening once again, everyone, and I heartily welcome each one of you on this busy day. Obviously, it is a Saturday evening, but still, I thank everyone for your presence here today for mainly discussing on the worsening heart failure aspect, particularly the patient profiles that we are looking at in the worsening heart failure and the practical implications that we are associated with the treatment in the worsening heart failure aspect. And today I would like to invite everyone here. Obviously, I requested Dr. Keshwasa to help me guide in moderating the discussion for today and take ahead the discussion. And along with the Dr. Keshwasa, we have Dr. Gigi Shetty sir, Dr. Nagraj Desai sir, Dr. Sridhar sir, Dr. Aditi ma'am, and Dr. Sridhara sir. So I heartily welcome one and all for everyone. And with this, I would like to ask Dr. Keshwasa to give a brief intro of our guest speaker today, Dr. Ponikowski. Yeah.
Good evening. I think it's my pleasure to introduce Dr. Ponikowski. He is the director of Institute of Heart Disease at University Hospital, Poland. And his main area of research is on heart failure. He's a co-author of more than 900 peer-reviewed papers and citation. He's one of the most influential scientific minds in the world, and is former president of Polish Cardiac Society and president of Polish Heart Failure Association. He's a chair of ESC Heart Failure Guidelines 2016 committee, and he is also member of executive committee member of Victoria trial, for which we are going to see all the details. And with this brief introduction, I ask Dr. Pankowski to give his lecture.
Well, first of all, thank you very much indeed for your kind invitation. And I would like to apologize that I am not able to join you in person, although I was in India only a week ago and had a fantastic 2-day discussions with colleagues. Once we were discussing the issue of worsening heart failure. Let me just start sharing my screen, but I'm sorry to say that can you see my full screen?
Yes, Professor.
Okay, thank you very much. So once again, I'm terribly sorry that I'm not able to travel in person, but on my way back, I got some nasty virus and I stayed home. Today is better, so I'm recovering and I hope to see you in person in the near future. So once again, my apologies, and I would like to thank you very, very much for your invitation. As we already heard, today we are going to discuss worsening heart failure, which in my humble opinion is one of the most challenging elements, parts of the natural history of heart failure. And let me just, with a very brief introduction, give you the data from and interpretation of Victoria clinical trial, because this is the only trial whatsoever prospectively focusing on this population. These are my disclosure. Particular importance from my perspective is that I am involved in the development of vericiguat for many years, and I had the privilege to start working on this drug many years ago with Mihai Georgiade, whom you I'm sure know very well, who prematurely died, and it was a Socrates program, followed by the Victoria and now Victor. And if you are interested, I would be more than happy also to discuss with you the Victor concept at the end of this presentation. So let me get back to the concept of worsening heart failure. As I already mentioned, heart failure, as we all know, is a progressive condition. These timelines depicted on x-axis may well be a different timing. However, we know very well that despite optimal medical and device therapy, in many patients, there are periods of destabilization, there are periods of decompensations, there are periods, despite we are treating them in an optimal way, there are periods when they develop heart failure signs and symptoms, and they need to be either admitted to the hospital, or more and more often now, they can be also treated on the ambulatory circumstances. However, regardless, as I mentioned in this definition, regardless of location of care, in all circumstances, in hospital and at the emergency department, ambulatory care, episode of worsening heart failure always is related to very poor outcome. So that's something extremely important. And although we take for granted that the problem of rehospitalization may be actually decreasing, is the other way around. This is the most recent summary of epidemiology over the last 40 years. As you see, this is a paper written by the group led by my very good friend Alex Mevazah. As you see here, 4 decades, 40 years, analysis from Asia, Europe, and North America. The 30-day rate of death after hospital discharge is decreasing a little, not that dramatically one. However, the readmission rate, which is highlighted in red on the right panel, is still increasing, again, despite all our efforts to optimize therapy. I'm sure the same in your country, in Europe, and in my hospital, I'm in charge of the big cardiology, cardiac surgery department, and there are at least 10, 12 admissions, acute admissions every day, of whom at least 50% are due to heart failure worsening, are due to decompensation of heart failure. This is a growing problem, and I'm sure the same in your country. During my discussions with Indian colleagues, I realized that in your country, having 1.4 billion people, even with 2.5 prevalence of the disease, 5% of prevalence of the disease, we are talking about 30, 35 million people with heart failure and 100,000s, if not millions, admissions due to worsening heart failure every year. So this is a real challenge and real clinical problem. And I'm very open for your questions, why I humbly present the Victoria and my understanding of worsening heart failure. And at the end, I prepared also 2 cases, but it's up to you to decide and comment whether we should proceed this way. But I would like to reiterate today that despite our great belief that the problem of worsening heart failure may well disappear because we have this fantastic four, we have this quadruple therapy, we have these devices. This is the recent analysis we did based on DAPA-HF. Please remember, patients optimally treated, patients in clinical trials, so very well, very carefully, very thoroughly followed up with ARNI, beta blocker, MRA, dapagliflozin, and still 1 in 7 of these patients, only within a relatively short period of time, because here the median follow-up was in the range of 20 months, experienced either death or worsening heart failure event. So this is a problem, and that's what we need to somehow address in our clinical practice. From this slide, so then don't get me wrong, I'm not going to self-promote ourselves, myself and my colleagues, but once we wrote the guidelines 2016, I had the privilege to chair a group of fantastic colleagues from Europe. We decided to, at that stage, we didn't use the word worsening, we used acute heart failure, and I must tell you that it was 6, 7 years ago, many of us still perceived acute heart failure as an entity, as an episode, which in virtually all cases should be hospitalized. Now we see that there is a certain group of patients which can be treated in the ambulatory basis as well. However, so let's use the wording worsening heart failure. As you know, as you can see here, we pointed out that this period is indeed the best to initiate and up-titrate disease-modifying pharmacological and device therapy, and also plan very carefully, if you see this statement here, post-discharge follow-up in terms of pharmacological therapy optimization, in terms of telling the patients and the family how to handle the disease, who will see them when, what about non-pharmacological approach in order to prevent early readmission. This slide we are showing very, very often because this is the concept Lynn Warner Stevenson and colleagues developed more than a decade ago, showing that in fact, after heart failure worsening, the initial phase lasting couple of weeks, 3-4 months, maybe a little bit longer, is indeed the most vulnerable phase for which, as she says, evidence-based strategies are absolutely needed to prevent readmission, to decrease the risk of readmission and mortality. And Victoria trial is the only trial whatsoever focusing on this transition phase. We are saying worsening heart failure and the post-worsening heart failure event, because only these patients in this transition, most vulnerable phase were indeed recruited. Long time ago, for many years, we developed the concept, we developed the paradigm that therapy of worsening heart failure, the therapy of acute heart failure should be focused, should be restricted to an early phase. You very well remember of this, all these trials focusing to treat the patients within this couple of days hospital stay, worsening event, decompensation. We have borrowed the concept from acute coronary syndrome from the concept, the earlier, the sooner, the better, open artery, etc., etc. It stays very true in acute coronary syndrome. However, this concept failed. Sorry to tell you. Now we are moving to different paradigm. And now we are moving to a concept that early initiation of a peri-discharge phase, so the compensated patient, either pre-discharge or soon after discharge, being optimized and then followed, so with a transition to chronic care therapy. And I would like to draw your interest to these 5 clinical trials, Pioneer, Victoria, Soloist, Affirm, and Impulse, which actually didn't fail, which actually provided pretty promising data that with this new paradigm, we can really change the outcome. For your perusal, Victoria focused on this particular kind of a timing around heart failure journey, as you can clearly see here. It is a recent decompensation. Patients were recruited exactly as I mentioned in this transition phase, vulnerable phase, which is actually depicted here in red by very high event rate. So this, although these patients were stabilized and sent home for further management or recruited in the very recent post the worsening heart failure in this period, if you look carefully, the event rate is much, much higher than in patients with chronic ambulatory settings. The rate is 3-4 times higher than in this ambulatory chronic heart failure phase of the disease, which I would like again to reiterate. So we are really talking about patients at risk. And this is just an introductory slide showing that in Victoria, with more than 5,000 patients recruited either to placebo or vericiguat, I will show you in a second the study design, all were admitted in this vulnerable phase, many of whom, if you see 84% were were hospitalized for heart failure within 6 months. If you see, we were quite open for patients with EGFR not over 15 so I will show you that we ended up with a pretty reasonable number of patients with really compromised renal function. So a real population and population difficult to manage included in the Victoria trial. And this is just to make long story short, Victoria was designed to study patients with symptomatic chronic heart failure with ejection fraction below 45% on guideline-directed medical therapy, who despite of that experienced worsening heart failure event, either being hospitalized or being treated in the ambulatory basis with IV diuretics at least. Please remember that we recruited in the study patients who were in a sense of a recompensation, in a sense of clinical stability, already kind of a stable, not in this acute phase. We wanted all of them to be at least 24 hours of IV treatment and with at least systolic blood pressure of at least 100 millimeters of mercury. In other words, patients must have met criteria for a clinical stability. but very simple, simply defined blood pressure of IV therapy. And please remember that there was no run-in phase in this study. The design was very simple. Eligible patients, please remember I mentioned here, we extended for the first time EGFR, so we lowered the bar to 15. We ended up with more than 500 patients with EGFR between 15 and 30.
So we will invite, thank you,
elevated natriuretic peptides with recent decompensation randomized either to placebo or to vericiguat, but vericiguat was placebo and vericiguat where the drug was up-titrated. We started with 2.5. After 2 weeks, on the physician discretion, we up-titrated to 5 milligrams once daily, and after another 2 weeks, up-titrated on the discretion, on the clinical evaluation. The physician was asked to up-titrate that, if possible, to 10 milligrams once daily. Please note that at the end, more than 90%, overall around 90% of patients were on the optimal 10 milligram once daily dose. Primary endpoint of this study was time to occurrence of either cardiovascular death or heart failure hospitalization. So it was a very classical approach. Time to first event analysis, cardiovascular death or heart failure hospitalization, which occurred first. This slide, just for your perusal, summarizes the concept why we decided to use vericiguat. You are the best cardiologist in the country, so I'm sure that you are pretty familiar with this concept of nitric oxide soluble guanylate cyclase, CGM, cyclic GMP, as a target for therapy in pulmonary arterial hypertension. With riociguat, we used this long, and we are still using it. And this was the concept valid many years ago, also with the application for heart failure syndrome. As you look here, vericiguat provides a different approach because it is a different pathway, we believe, not targeted by Fantastic Four or all of the available therapies. You may very well remember RASI, or maybe I should rather say neuroendocrine activation. I remember when I joined London Group many years ago, 30 years ago, and Philip Wilson used to teach us that this neuroendocrine and pro-inflammatory activation were the key elements of the pathophysiology and should be targeted. And then several trials were set up and provided the evidence. Only recently we had ARNI, and only very recently we had we have SGLT2 inhibitors. Nobody really understands how SGLT2 inhibitors tend to work. Nobody understands the underlying mechanism. They work fine. However, this nitric oxide cyclic GMP signaling is an important part of the whole story. This is the cartoon we developed once publishing the design paper for Victoria, putting forward that restoration or insufficient soluble guanylate cyclase, cyclic GMP signaling may well be considered based on preclinical and early clinical studies as a novel target for therapy in patients with heart failure. It's not about cyclic GMP, not enough, or this pathway to be not efficient, not sufficient enough, but about downstream signaling of cyclic GMP with several kinases, with several biochemical processes. Myself as a clinician, I'm not even able to understand, but definitely a lot of data showing that impaired signaling of down signaling of cyclic GMP may well be a quite important target for therapy with a lot of preclinical and early clinical studies. Vericiguat, as you know very well, carries dual mode of action. One is nitric oxide independent via direct stimulation of soluble GC, and one is related to endogenous nitric oxide, as vericiguat enhances sensitivity of soluble GC to endogenous nitric oxides, and as a net result, this impaired signaling is restored. So we hope it worked. This is the very brief baseline characteristic of patients included in Victoria for your perusal. More than 500 patients tended to have a EGFR between 15 to 30. So not only efficacy, but also safety, which we also were concerned once planning the study, can be discussed with that number of patients. 60% of patients received triple therapy. You can say, what about Magnificence 4? Sorry to tell you, planning the study, we have no clue that as GLT2 inhibitors would become so soon number 4 element of life-saving therapy. As you see, 2/3 of these patients were hospitalized only within these 3 months. In other words, this very vulnerable phase, patients with their late 60s, early 70s. And this is the final and the main result. Vericiguat added on the top of guideline-directed medical therapy in patients with recent worsening heart failure event, significantly reduced the rate of cardiovascular death or heart failure hospitalization, and annual number needed to treat is 24, with absolute risk reduction of 4.2 events by 100 patients. Yeah, whether this is a clinically relevant number, declaring conflict of interest, in my humble opinion, yes, and I will show you the comparison of the magnitude of the effect of vericiguat versus other recent trials, versus other molecules, other therapies tested in recent clinical studies in heart failure patients in a second. So significant reduction, and here are the secondary outcomes. There were numerically, but not statistically significantly less deaths, but what really matters is the reduction of heart failure hospitalization, not only first, as you see here, but also total heart failure hospitalization, which is, as I say, pretty relevant, particularly in this patient population, with recurrent hospital admission being the major, or one of the major elements of the heart failure burden, also economic burden we are facing now. As I already alluded to, I would be more than happy to confront Victoria trial with other recent clinical studies with patients, with heart failure patients. Galactic, pretty similar population as you see here, with a little bit less events, however, still very, very, I would say, vulnerable as well population, with absolute reduction of 2.1. Emperor and DAPA with a similar to Victoria absolute risk reduction in paradigm, also depicted here with absolute risk reduction of 2.7. So a clinical implication, clinical magnitude of the result is pretty similar and pretty in favor of the new compound vericiguat, at least based on the Victoria trial. What about safety? I'm sure that many of you would have the overwhelming evidence, because I heard visiting India only a week ago that the drug is available on the market, and many of colleagues whom I talked to already told me that they have first patients already and first experience with the drug in everyday clinical practice, which is a great story because soon you will be much more experienced than myself, being only in Victoria. In my center, we tended to recruit many patients to Victoria. We tended to treat many patients in the previous trials, Socrates program, dose ranging studies with HFpEF, then Vitality with HFpEFs, and now Victor. But this is restricted evidence, restricted to clinical trials. You would have a greater opportunity to tell the whole world how it works in clinical practice. But in clinical trials, we have a very clear signal. Vericiguat has a favorable safety profile. In the context of adverse event rate, as you see here, there is no difference. In the context of hypotension, we were pretty concerned planning the study because, please remember, very vulnerable population at risk of potential development of hypotension or hypotensive events, which may well be leading to a serious deterioration. As you see here, no difference in the rate of symptomatic hypotension, 8 versus 9%, so virtually the same number. Please also remember that 90% of patients remained at the max target dose of 10 milligrams once daily. Once we published the data first in New England 2 years ago, there were at least more than 15, if I count correctly, nearly 20 papers based on the sub-analysis from Victoria. Very intriguing data in many specific phenotypes of patients, which I would be more than happy to address if you are interested, obviously. Renal function, optimal medical therapy, recurrent events in order to prove that the drug reduces recurrent events as well, and blood pressure are 4, which I'm going to tell you about. But again, if you're interested in several other analyses which we did, I would be more than happy to share my experience because I am virtually in all of these studies. And if something is not done yet, I'm sure that we soon have the publication committee meeting, if I'm correct, on Tuesday. So I can easily say that colleagues want something like additional data on this or that, and it would be very well appreciated. So why not we start with renal function? As I mentioned, we can clearly say that vericiguat provided benefit across all EGFR categories. And even more importantly, or equally important issue, is that although patients with this low GFR, below 30, this is pretty unique population in clinical trials because 15 to 30 is the population not really quite being welcome in the clinical trials due to potential adverse events and difficulty to handle this, to manage these patients on the everyday clinical basis. So we recruited, as I said, more than 500. It's not only about efficacy, but also about safety. The drug is safe, and we have clear confirmation here. Regarding the trajectory of potassium, sodium, mainly potassium, in the trial, is pretty comparable to placebo. So it's very good news. What about ARNI, concomitant use of ARNI? This is a question I am receiving quite often. What about potential hypotensive effects? I will show you in a second. But if you take into consideration efficacy, patients being treated with ARNI or not receiving ARNI at baseline, they benefited in the same way. And also regarding safety, there is no signal that a combination of these 3 drugs plus vericiguat, using ARNI plus vericiguat, will lead to increase of risk of adverse events. this is pretty important analysis as well, showing that irrespective of time from the worsening heart failure event, so irrespective of patients being admitted and treated within the recent 3 months, or 3 to 6 months, or being treated on the ambulatory basis with IV diuretics, vericiguat works very well. As you see here, there is no heterogeneity here. What about recurrent events after initial hospitalization? The same consistent reduction across all these groups. So recurrent hospital admission, the risk of recurrent hospital admission, not only first, but also recurrent, not also second, significantly reduced. And now let me focus for the next 1 minute or 2 minutes on the systolic blood pressure. We are receiving questions, what about systolic blood pressure in the population of patients with recent decompensation? Although, please remember, already stabilized. So we wanted patients with systolic blood pressure of 100 and above not being on IV therapy, so stabilized phase. As you see here, the systolic blood pressure profile over time was not different versus placebo. Some of us may wonder, what about this initial drop? There is I'm not saying that this drop may not occur. It occurs and will occur. However, it also occurred in patients being treated with placebo. So initiation of new therapy, regardless it was placebo or vericiguat, tended to be associated with a decrease in blood pressure in the overall population. It was not in the range we observed with ARNI. However, it may happen. So we can't really say that we should not take this into consideration, but there was no difference between placebo and the vericiguat, and it was in the range, as I am saying, in the whole population of 4 to 5 max millimeters of mercury. As I already alluded to, once we were planning the study, we were particularly concerned. You never know what will happen in clinical practice unless you do the trial, who are potentially vulnerable to drop in blood pressure. We considered older patients, patients with lower systolic blood pressure, and those receiving ARNI as those who may well be a vulnerable subgroups. As you see here, it was not the case in patients over 75, but as you see on this slide, there was a certain drop, initial drop in this subgroup. So please remember that it may well happen. What about patients with initial systolic blood pressure in the lower range, between 100 and 110? Paradoxically, there is an increase, as you see in this. Paradoxically, what we expected. So again, quite a reassuring finding. And what about those on ARNI? There was no difference between vericiguat and placebo, as you know. So again, quite important message. Another story is how to position, how to communicate now this. You are, as I'm saying, top cardiologists in the country. I don't want to persuade you to use this by slides or to come across with this message, but we now want to make sure that we have a clear message and communication to our colleagues. I will show you 2 or 3 slides we prepared to communicate with general practitioners, with internal medicine specialists, because in most countries, I'm sure the same in India, 40 million heart failure patients cannot be treated only by cardiologists, also once they experience worsening heart failure. So we put this together, showing the safety profile. We also very often refer to very recent guidelines European guidelines, American guidelines, Canadian guidelines, for the first time mentioned the word worsening heart failure as a specific uh, part of heart failure journey, which should be treated in a different way, may occur and occurs in clinical practice despite optimal therapy, and very what should be the drug to be considered in this particular worsening heart failure period. Make it this when recommended by European Society, American College of Cardiology, and Canadian guidelines, very recent publications. So this is my humble summary. Where does vericiguat fit on the basis of Victoria? So we have patients on optimal guideline-directed therapy. They experience a event of heart failure worsening, and we humbly suggest to strongly consider adding vericiguat in this circumstances. Again, this is one of the slides we prepared from for our colleagues, for our general practitioners, those in there who being involved in the management of patients who are decompensated and treated in the hospital, because as I'm saying, in my country with 150,000 admissions, only a fraction of these patients can be treated in cardiology departments. So scenario number one is a patient who is in hospital and he's ready for discharge. He is on optimal therapy, he's stabilized, and please consider him as a candidate. Then there is a nice lady who is actually at the first post-discharge appointment in order to optimize her therapy. It's pretty common now, at least in Europe, that we invite patients after discharge for the follow-up visit to optimize therapy, to check biochemistry parameters, to check whether everything goes smoothly. So she's also a good candidate. And the last lady is not a patient from the hospital. She was treated on the ambulatory basis with, I would say, up titration of the therapy, optimization of therapy. She actually received IV directed. So and in this case, due to worsening symptoms, and this lady is also an ideal candidate for vericiguat to be considered. And my final slide, Victoria implications for the therapy. First of all, I would like to humbly focus your attention that we have new pathophysiology, we hope. If you challenge me further, I would say we believe this is a new target, the pathway targeted. But again, only mechanical studies in the future can or will tell us more. We definitely have a new patient population who, despite receiving guideline-directed medical therapy, experienced heart failure deterioration. With vericiguat, we improved cardiovascular outcomes, and the drug is very well tolerated and safe. So that would be my humble summary, and I'm very happy to take questions. And if you are interested in the next after we discuss after I address your question, then we can discuss one or two cases I prepared for this afternoon, this evening, in order to see whether you accept the certain approach I can humbly propose. Once again, thank you very much for your kind invitation.
Professor, we were discussing that you should give the second half of the talk so that we'll keep the questions at the end.
It's absolutely up to you, but the second part is about is about cases. So if you are interested in particular aspects of the trial,
Yeah.
I think now can be a little bit better moment. But if you want me to present one or two cases, is equally okay. I think that maybe now, if you are interested in the details of the study, I can share with you based on what we have and what we learned from Victoria. I would be very much, but I entirely leave this up to you.
What do you feel? Sir, you can go ahead. We'll have questions at the end of your talk, second talk.
Fantastic. Okay, so let me proceed very briefly. Uh, the the first case is a case. I am sure that you may comment on the case and then comment on the trial. This is a patient, a typical case we are seeing very often. HFrEF patient diagnosed with ischemic cardiomyopathy 10 years ago. He was pretty stable with heart failure diagnosed, as I said, nearly 10 years ago after anterior MI. Fairly stable. In 2020, hospitalized, re-evaluated with ICD implanted. And after 2 years of being fairly stable, he was readmitted due to heart failure event. Worsening heart failure event with progressive dyspnea, peripheral edema. That's the major part of the whole story. Wet patients. Again, I would love to discuss this if you are interested. He, on the ambulatory basis, at the same time, he was in this rivaroxaban, sacubitril, valsartan, bisoprolol, toracemide, atorvastatin. He was diabetic, so I can only apologize that he was not on SGLT2 inhibitor. Please remember, this is something which is still, at least in Europe, not that commonly used yet. I'm not sure what about your country. We are seeing increase, but not even in diabetics. He is with, as I said, CKD, coronary artery disease. Here are his vital signs at hospital admission: blood pressure around 100, heart rate of around 85 to 90 in atrial fib. There was no signs of acute ischemia. Initial echo showed ejection fraction in the range of 30% with impaired EGFR in the range of 40. That would be baseline with pretty elevated NT-proBNP in 4,000 range. Here, I would like to kindly ask you whether how you optimize the therapy. Obviously, we can debate how to handle this initial phase, how to handle the congestion. I would be more than happy to share our experience with decongestive strategies, how to handle, if at all, because please remember that he's the patients with ischemic cardiomyopathy, how to handle issue of ischemia, how to handle the issue of moderate functional mitral regurg. I am co-PI of Reshape trial with mitral clipping, so I would be more than happy to comment on this based on our approach. But here, I would mainly show you the pathway, the natural history of this gentleman in this way. Second, hospitalization. But after pretty stable phase of ambulatory heart failure, that's the guidelines, European guidelines, evidence-based oral medical treatment administered before discharge.
Professor,
and what, yes.
uh, sorry to interrupt. I think the screen is frozen for the Bangalore symposium. So they are having some network issues. So, Rani, if you can just give us a heads up if we are good to go and Professor is audible, that would be great. Hello?
Hello.
Yeah, ma'am. Yeah, it's a good to go now. Yeah, we can hear
Okay,
you.
fine. Right.
Okay, shall I repeat everything?
So,
You
from
can
where do you
continue.
want?
Yeah, from this slide, it's okay, sir.
Okay, so as I mentioned, second decompensation, clear, stable pathway at the beginning, then decompensation, again, stable, natural course, and now destabilization. We can discuss what other preventive strategies we may take. Here we have recommendation from our ESC guidelines. Please remember that, or if possible, oral evidence-based oral medical treatment should be administered before discharge with class of recommendation 1. Now, this is a pretty recent analysis, meta-analysis of all recent studies showing that combination, if possible, it's not always possible, as you know very well, but if possible, is always related to a better outcome. And it would be my humble comment whether you like this this discharge therapy in this gentleman, or you would be entirely inclined to something different. So I am very happy to take your comments. I am very happy to be challenged, and I am very happy also to discuss some other aspects you may well be interested.
I think the line of treatment looks good. I had only one question. When do you want to put this patient on a transplant list? You want to do a mitra clip apart from this, or this is fine and you want to wait for 3 to 6 months and then see the next step?
Well, that's a great question. First of all, I can tell you that we initiated pretty active transplant program at my institution. Last year we did 40 transplants. This year we did by yesterday, because I am receiving information on everyday basis, we are at the 31st this year. So we are in the range of 40 to 50 transplants per year. So we have a pretty active program. This gentleman is in his 70s. I'm sorry to tell you that in Poland, once we initiated the program, the level was, the cut level was in the range of 65. Now we are a little bit more towards late 60s. Point is very well taken. But if we consider him, say, 8 or 10 years younger, make it this way, he's in his 60s, early 60s, and he's with ejection fraction of 30, I would say that we would give him some time and some chance not to be yet on the program, transplant program. This is second decompensation, and actually after 2 years of the recent, he was pretty stable. You can challenge me by asking, what about the therapy? I would say we believe that on the ambulatory basis, it's a very good point. I would love to comment. His therapy was not optimal. He didn't have, despite being diabetes, he didn't have SGLT2 inhibitor. His therapy was not that optimal. With vericiguat, we would love to see what is going to happen. He is in the ideal phase of heart failure, natural history to reevaluate whether everything is optimized. Regarding mitral regurg,
his mitral regurg was in the range of moderate. I can very well remember the discussion we had only a few weeks ago in Barcelona at the European Society of Cardiology. What is the optimal therapy for these patients before we consider them as a candidates for mitral clip? Actually, maybe I should even say not mitral clip, but interventions on the functional mitral regurg. We believe that optimization of therapy, including vasodilation, including afterload kind of a manipulation, in a sense, decreases, as you know very well, magnitude of the, in many cases, and also control of the rhythm will result in many cases decrease in the severity of mitral regurg. So we definitely, in my humble opinion, would wait a couple of weeks, treat him optimally, and then reevaluate in the context of his functional mitral regurg. He already has his ICD. There was no ICD file, so there was no shocks. So in this aspect, he's pretty stable. Regarding his reduction of the risk of potential sudden death, I believe that sacubitril and DAPA, for which we have a clear evidence that they may affect the sudden cardiac death, or there are several publications on that as well. So I believe that now he is optimally treated and just needs a careful follow-up after discharge. That would be my humble opinion, but I hope that I addressed your concern regarding heart transplantation.
Yeah, can I? He is not on aldosterone antagonist. Is it because potassium is 4.9 or?
Great question. Thank you. It is indeed not really a mistake, but what we want. I understand that you are pointing out at the concept, what should be the optimal combination of therapy in this patient. Fully agree that he should have mineralocorticoid receptor antagonist to be added, yes, but because we have a chance to see him after 4 weeks post-discharge, we decided to initiate, we consider this as an important part of therapy, absolutely no doubt. And we, sorry to say it, I thank you for this comment, we consider either a plerinone of spiral to be added in his on his next visit. But point is very well taken, no contradiction. So yes, indeed.
One more, just one more doubt. In case if was the patient already on GDMT and he came back second time with heart failure, or was the drugs as per the GDMT? Was the patient taking medication?
We consider guideline-directed medical therapy nowadays being composed of Magnificent Four, no doubt. But, and here one can say, and what? So what to do if the patient is already on this optimal, really very recent, in the sense of how we understand guideline-directed medical therapy. I would say adding vericiguat is an ideal scenario here. We strongly believe in it. You can challenge me by saying, okay, you don't have the data with SGLT2 inhibitor from Victoria because no patients on this. I would say, yes, we don't, but, and I can only concur with it, but yes, we believe that because there are different pathways, it's strong belief that it will work as well. With time, we have more data. Some people tend to ask, what about vericiguat to be the fifth pillar of guideline-directed optimal medical therapy? Why not to say fifth pillar? having such an evidence. And then I would say, quite recently, we published the Heart Failure Association of European Society of Cardiology before the guidelines. It was exactly 1 year ago. We published a document in which we strongly believe that the definition of guideline-directed medical therapy is based on phenotyping. Maybe I have one slide on this. Sorry, here I have one slide on this, yes. So in different phenotypes, you indeed may not only have magnificent 4, which is always in the middle, but also magnificent 5, or sometimes even magnificent 6, 7. I did not mention, for example, IV iron, which I consider, and here I declare conflict of interest, also a part of magnificent 6, for example. In the phenotype of patients, you tend to have iron deficiency. Here, if you have a phenotype of patients with recent decompensation, I strongly believe that vericiguat is a part of magnificent 5 then. So 4 plus the 5th element for which we have evidence. That would be my humble comment for your question.
The dosage of toracimide is 40 plus 20. And at what point of time you tend to reduce the dosing of this particular drug and consider MRA, as my colleague was pointing out? Because I personally feel 60 milligram of toracimide is a rather large dose. And also
Absolutely
I also want to add on, you did mention about sudden cardiac death being prevented by ARNI and also by DAPA. Surprisingly, you're not mentioning about beta blocker, which has been one of the ancient ones which has been shown to be so. Comments, please. And what is the mechanism of vericiguat reducing sudden cardiac death? Thank you so much.
Great question. I fully agree with you. Very big dose of toracimide may be a little bit questionable. There was as you see, a reduction in NT-proBNP from 4 to 2000. So a great story. Patients is, we tend to keep the patient in the hospital for the shortest period of time, because in most cases we see all these complications of hospital stay, mean infection, and so I am an advocate for kind of a treatment, and I push on this very hard on my fellows to keep as short as possible. So the concept, if the patient is able to come for a visit on the ambulatory basis, not living very far, I'm very much in favor of. But here, yes, you are right. On the doses, most likely he was on much lower dose. I would consider this as a 40 perhaps would be enough. Point is very well taken, and we don't in the clinical practice withdraw the diuretic even in patients who are pretty mildly symptomatic too quickly, because this is challenging, as you know very well. It needs it requires very careful evaluation and cooperation with the patient. So to make long story short, next visit definitely, if there is nothing like deterioration or increase in symptoms, cut the diuretic dose. Point is very well taken. What about long-term diuretic therapy? We like, because in Poland we have both Tora and furosemide available. We would definitely cut toracimide to 10-20 milligrams, see what's going on based on the symptoms and clinical evaluation. Regarding so point is very well taken. I can, if you wish, I can also comment on our in-hospital decongestive strategies, and also based on your comment that it is perhaps too much being or having DAPA. I fully agree, because DAPA also carries some decongestive effect. So yes, regarding sudden death, absolutely, there is no doubt that bisoprolol beta blockers are historically the only drugs with clear evidence to reduce sudden death. Absolutely no doubt. Yes. I only mentioned about sacubitril valsartan and DAPA because there are these two new compounds which tend to reduce the risk of sudden cardiac death. Sorry for this misinterpretation. Yes, no doubt, for many years we kept saying beta blockers tend to reduce sudden cardiac death. No doubt at all, based on large analysis. Regarding vericiguat, we don't have that data. Sorry. Regarding sudden death, we have data, as you correctly alluded to, on bisoprolol. We have data on recent analysis on sacubitril valsartan from Paradigm, and also we published the data from DAPA HF quite recently showing reduction in the risk of arrhythmia, including sudden cardiac death.
Thank you, Doctor, for this very educational talk. Just talking about these discharge medicines, we have other drugs also that have like a two-way indication. For instance, when there's renal dysfunction, as this patient seems to have, hydralazine isosorbide is also a combination that can be used. So how would you pick between either that combination or vericiguat as well as ivabradine? I noticed this patient's on maximal bisoprolol dose and heart rate is still in the high 70s. So those are also drugs that could potentially be added. And just with all of these 6-7 drugs that can be added, how do you reconcile, that with the patient and the issue of pill burden, etc.?
I can only say yes, concurring with you. Honestly, in my country, we do not have large experience with a combination of pretty big doses of hydralazine with isosorbide nitrate. No doubt that this is I would say, the period of decompensation, worsening, and the post-discharge phase, in my humble opinion, in this borderline, blood pressure borderline patients are not optimal for isosorbide dinitrate with hydralazine. We prefer to rather consider drugs with less potent hemodynamic effect. But to be honest with you, your point is very well taken. It may well be a good point to start, allowing also, for example, improvement in mitral regurg, better hemodynamic stability. Point is very well taken. Simply saying, in my country, in Europe in general, I believe that the experience with the combination of nitrate with hydralazine is not that large and that common. So point well taken, but I can only say we are not using this very often. No contraindication. Also recommended. I agree with you.
Would you try hydralazine alone without nitrate?
I don't have experience. We are doing this quite often. We did in the past, but in the patients we were treating, we had problems in the hospitals, despite with very advanced heart failure, trying to use vasodilatory components in order to optimize hemodynamics. May well work. I have no experience myself.
I think this patient is having atrial fibrillation. That's why ivabradine was not added.
Yes, he is with. You can challenge me by asking what about atrial fib. I can only tell you that this is one of my great beliefs at our institute. I don't know what you are doing. I am building up I have currently 2 EP cath labs. I am building up the third one to actually increase the number. Yes, last week before coming to India, we had a very good meeting with my electrophysiology team. I have 6 electrophysiology fellows, and we all agreed that at the current status, the current level of evidence, we need to build up the third cath lab immediately in order to perhaps also hire another experienced electrophysiologist. He's not on ivabradine because of atrial fib, but atrial fib itself, in this case, may well become a target for therapy, and we would be very much inclined to this. We believe that that in the future, perhaps maybe at earlier stages, it would be a good idea. With more and more time and better equipment, I think that's very attractive element of the therapy. I agree. It should be taken into consideration.
Thank you. Would you be considering digoxin?
Only if the symptoms persist, and only if there is no other way to control the rate, not as a primary choice.
Right. Choice. Do you believe it decreases hospitalization?
I do.
Okay. Thank you.
What about, are there any contraindications for usage of vericiguat, nitrates or other?
Yes, we don't want to use vericiguat in the combination of sildenafil and nitrates. Obviously, we will have more and more experience with the drug on the market, but sorry to say, in the Victoria trial, concomitant use of nitrates or sildenafil was a contraindication. But I'm sure that with time, with you having the drug in your hands, I'm sure that you have more and more experience with this. It was contraindication.
Thank you. If I may just ask an add-on question, there are people who ask that I wish to use sildenafil occasionally. So what medicine do I stop, and for how many days prior and after? Especially, those who are taking nitrates, we tell them at least stop 24 hours before and start 24 hours afterwards. So for vericiguat, if somebody is on, and if the patient wishes to use sildenafil, how would you guide him?
I can't tell you. I have no idea, to be honest. I can ask you maybe in a couple of months, because you would have more experience. We strongly discourage in this trial. We strongly discourage because it was a contraindication. I think it will occur, and it will happen. And I can only ask you if I come, if you invite me to share experience with some other studies we are doing, because we are doing many other trials. Soon we are going to tell more about this and that, maybe Victor in the future. So in the meantime, you would have, I fully agree. This is very, very valid question. Honestly, I can't answer.
Thank you.
Sorry, I know that you are disappointed, but I can't. You are very experienced people. I can't answer. Sorry.
Thank you. We have a lot of Middle East patients, and they ask these questions.
I know.
So thanks for this honest reply. Yeah.
Sir, we'll continue with the next case. Or?
Absolutely. This is just for your perusal, kind of a humble suggestion about optimization of the dosage. I am receiving questions. What about very stable patient with blood pressure in the range of 120, 130? What about starting with 10? And my answer would be, your clinical practice will guide you. But what we did in the trial, we always started with 2.5, followed by 5, followed by 10. And here is also this suggestion related to sildenafil is not recommended in conjunction with, this is my statement, and official label. But I'm sure that with time, again, like with sacubitril valsartan, although we are told, and from the beginning, I remember 5-6 years ago, much more potent hemodynamically drug, we started with a small dose. Now, in some patients, we are inclined to a little bit more kind of a fast track option. But I'm showing you this for for your perusal. I have a second case just to give you a hint what you would do in order to make sure that you tell me more than I tell you. This is a young lady, 59, diagnosed with HFrEF a year ago, rehospitalized with a heart failure worsening 2-3 weeks ago, stabilized, not that bad story. In other words, she did well, short stay in the hospital, fluid overloaded, discharge with the following therapy: sacubitril valsartan 4951 BID, metoprolol 100, eplerenone, DAPA, furosemide, now reduced, initially 60, but she takes, now she takes 40. And now she comes to us after 2-3 weeks on her first follow-up visit with EGFR of 25, drop from 40, so it's pretty significant. Potassium increased from 4.9 to 5.7. Blood pressure in around 100. So decreased renal function, elevated potassium level, and she's pretty stable, however, still in NEHA class 3. Sorry. What would be your suggestion? It's not easy, I presume, to handle.
Yes, if I may ask to handle this patient, maybe temporarily we could stop sacubitril, valsartan, and replace it with isolazine if it's available, and 1970 NT-proBNP is, I think, fair for somebody who's been 32% of ejection fraction, and we could be a little less aggressive with diuretics. I think first would be to reduce diuretics and sacubitril valsartan primarily for potassium going up, and also look at the eplerenone for a while, or you could keep them and give some potassium correcting measures if we can.
I don't know whether you have in your country
K-oxalate?
Yes, whether you have new drugs available. Sorry to tell you, they are not that widely available in Europe. In America, they tend to have these compounds now available, not only in clinical trials but on the market. Point is very well taken. 5.7 is what we worry about. Yes.
In India, we usually use K-oxalate, potassium binding resin, which nephrologists use very often, and it tends to get potassium low very quickly at this point. And would you truly believe that the mortality benefits are maximum with beta blocker, then probably an SGLT2 inhibitor, then an mineralocorticoid receptor antagonist, then lastly sacubitril? So if there is one molecule among the four, if you have to withdraw, would that be a sacubitril valsartan first, or eplerenone for hyperkalemia or worsening renal failure?
First of all, I'm very glad that you pointed out that kind of a error or mistake people tend to do is actually to use too high doses of furosemide, diuretics, unnecessarily. So point is very well taken. Second, answering directly your question, taking this, having this scenario, I would temporarily withdraw eplerenone. Please remember that she only recently received DAPA, so this drop in creatinine may well be a temporary drop related to DAPA, but I can't guarantee that with time it will improve. Point is very well taken. So out of two you're asking me, I would temporarily withdraw eplerenone and wait a little while and see what is going on. I don't know what you think.
I largely agree with you.
I think it is right. Better is to reduce the dose of diuretic, withdraw eplerenone, and probably sacubitril/valsartan also should be withdrawn. And once the creatinine stabilizes, I think you have to reintroduce sacubitril. So the question will be whether you will introduce sacubitril first or eplerenone first once the creatinine and potassium stabilizes. That will be the.
Now, with the current guidelines telling us that the beta blockers and SGLT2 inhibitors may be the first ones to be introduced in a hemodynamically not very stable patient, and then adding on eplerenone and sacubitril in that order, probably we could also reintroduce in the same fashion, knowing that SGLT2 inhibitors may temporarily cause decline in creatinine, but availability of urea would have been a good indicator here to say whether has it been over diuresis than just having the creatinine. If urea is significantly high, then definitely furosemide need to just go out completely, and temporarily we could even rehydrate the patient. And when we reintroduce, I think again it would be a SGLT2 inhibitor and a beta blocker would continue. And among the eplerenone and sacubitril valsartan, maybe eplerenone first and then sacubitril valsartan. What do you say, sir?
Well, thank you. I think, as I say, this first of all, this potassium binder story with the recent concept with patiromer. We don't have this patiromer available, but I heard from colleagues from America that they have this and they are using it. So in the context of hyperkalemia, I agree with you that sometimes, and that's what I keep telling my colleagues, my younger fellows, that sometimes even in heart failure, instead of decongest, you need to consider a little bit different approach to stabilize. I agree with you that sometimes over-diuresis, and we follow not only creatinine but also urea. We follow creatinine to urea. We do urea as an indicator of also of some adverse events of too fast decongestion. Point is very well taken. We also follow hemoglobin and hematocrit because we are quite inclined to the concept of too fast intravascular decongestion, too short without. So I have very strong opinion. I don't want to bother you with this, but in general story, yes, this is difficult case. It's not that simple. Obviously, in the context of our discussion, that vericiguat is on the market, I don't see here any contraindication in this case to in this scenario to add vericiguat. Again, with a small 2.5, 5, and then 10. But all points you raised are very valid, and I can only say it's not easy to, it's not kind of a case we have a list of drugs, we add one and go with it. May occur, and it's not easy to handle and give so careful consideration. A young lady as well, some of you may say, what about future? What about placing this lady on the transplant program as well? In the future, obviously, don't get me wrong, we need to do something around the therapy. I am more inclined in the context of renal function and hyperkalemia to eplerenone more than to sacubitril valsartan, because in sacubitril we are not seeing this very often. Your colleagues from India actually told me that adding vericiguat, they observed stabilization in renal function and improvement. That's what I learned last week, but we will see. In the context of our discussion today, I wouldn't be worrying about adding vericiguat as well. But all points you raised are very valid points in my humble opinion.
Yes, sir, you can continue then. Next.
Well, I don't have more. I just have one final to tell you about Victor, which would be a little bit different approach. Victor is about patients without recent worsening event, because many colleagues tend to raise the question, what about intervening with vericiguat earlier? Not late, but earlier. What about intervening before heart failure decompensation? What about those who already survived this and are in this post decompensation event, so not really worsening heart failure, but ambulatory, more stable phase of HFrEF. This is the whole background for Victor, and I'm sure that sooner or later, I think in 2 years from now, maybe 2.5, we would have data from Victor, HF, and then we will be rediscussing the whole concept again. By that time, in your country, having wide availability for vericiguat, you would have a great experience, and you would tell us more. That would be my humble last slide. If you would like to comment, ask me other very experienced cardiologists, I would be more than happy to share my experience with you in the area of heart failure.
Why, although the reduction in heart failure events were comparable in all the drugs, why was there not any death reduction in this trial?
Well, I think that several elements can appear. I can tell you that numerically there were less. There was not kind of a signal towards, look, there are only heart failure events reduced, not and with potential hazard above 1. So numerically there were less. I can only tell you that my humble interpretation is that the duration of the study was too short. We faced the same, I can only tell you, we faced the same in our AFFIRM HF trial, where I am receiving the same questions. Briefly, we corrected iron deficiency with IV iron in decompensated patients, and we reduced the risk of heart failure hospitalization by 24%. And there was no signal on deaths. People tend to ask, guys, something wrong, because you should see this as well in the context of heart failure related deaths, cardiovascular deaths. Point is very well taken, but similarly to the Victoria trial, we only had 1 year follow-up. So it may well be the point. If we are now awaiting some other analysis, and also real world evidence will tell us more. That would be my interpretation, but point is well taken.
Last question from my side. Since there are no clear guidelines where for us, so as a practical advice, when will you introduce this and how will you escalate the medicine? Means from the practical point, means practice point of view.
I can only say the guidelines from Europe. First of all, I believe that we will have soon the document addressing exactly what you are saying. But this is not the guidelines, because in Europe, European Society of Cardiology restricts the word guidelines to a scientific document issued every 4 or 5 years, summarizing only clinical evidence-based medicine, only based on that's a very restricted word. We are planning to issue the guidance paper or the consensus paper recommending this phenotyping, and we already issued this some months ago, recommended with clear recommendation how to use it. And in brief summary, what I discussed, 3 different pathways, 3 different scenarios. One is heart failure, hospitalization, stabilized, ready go home, please consider adding vericiguat. Second, or kind of a post follow-up, a post-discharge follow-up visit, please consider if there is no contraindication, and in those who were recently decompensated and not necessarily admitted to the hospital, please consider the start. And I will remain in the range of not fast, but rather slow, not too slow, but slowish up titration, 2.5, 5, 10. That would be my humble comment.
So one point we noticed in your slides, third and fourth hospitalization, it didn't work. So it doesn't work in really end stage heart failure 1. And the second one is BNP levels 8,000 and all, the benefit was low. So all this says that it may not be really useful in really end stage heart failure.
Great question. I am more than happy to address them. For third, fourth, not enough patients. So as you know, this is still taking the totality. There is no heterogeneity. In other words, there is no evidence that it works or does different way. Not enough patients with more than 2, 3. With time, obviously we would have more, but within a certain limit of follow-up, there are not enough patients to give you this confidence far to the left, showing this is below 1. But the issue you raise is, in my opinion, even more important. What about those with very, very advanced heart failure and very high NT-proBNP? Great question, and I can, if you have time, I'm sitting at home, so I have time, so I can share my experience with you. Can I? May I? With this NT-proBNP story?
Yes, sir.
Good. So I don't want to deprive you from dinner. It's perhaps 9 o'clock in India. So, but this is fascinating story. Once we published the original paper in New England, we obviously performed the analysis in all pre-specified subgroups. In all subgroups, vericiguat worked. All but one, very high NT-proBNP. We initially analyzed quartiles. In quartile 1, 2, 3 worked perfectly well, far below 1. Out of the 7, in quartile 4, didn't work at all. It was even towards this potential deleterious effects. It was quartiles. There was no harm, but a signal that it is something there. We published this in New England and then did a reanalysis. Justin Ezekovic's first author. This time, he took not quartiles, but continuous NT-proBNP value. And using statistical analysis across all NT-proBNP, because we tended to have, as you pointed out, many patients above 5,000, 6,000, he developed the number 8, magic 8,000, above which it may be not good at all to use vericiguat. Some people tend to ask, what is this about? Quite recently, we again reanalyzed this mysterious NT-proBNP level, and we have a very clear evidence that sort of 8,000 and above is not good. Some people may have benefit, but overall they may be even harm. So maybe then we 5,000, 5,500 is a very good, reasonable number, overwhelming positive results. And actually all these results are diluted by potentially deleterious effects in this very high NT-proBNP. And now you challenge me the question, what is this about? I truly agree with you that those with very advanced heart failure, 4th, 5th, 6th, maybe even 3rd hospital admission, they were not good candidates. Because, as also for sacubitril valsartan, this may be the stage in which manipulating about all these pathways may well not be enough. You remember the study with sacubitril valsartan in this very advanced heart failure, also didn't work at all. Another group of patients with these high NT-proBNP values in their 8,000 values are those who are not optimally decongested, who are not optimally treated, who are not euvolemic. So why not to try, sorry, this is my opinion, and you may have a different one. This advanced story is one, but some patients may have a very high value. Why not to try to, as you correctly said, recompensate or make them euvolemic a little bit better, and then recheck NT-proBNP. And if there is a drop, I think maybe a good candidate for the residual. It would be my humble interpretation.
Thank you, Professor. I think it was enlightening and we had a lot of good discussion. We really thank you for your time and thank you for clarifying all our doubts and especially the case scenarios were good. Thank you again. I think
once again, thank you very much. I would love to see you in person, perhaps soon.
Thank you, Professor, and I thank once again for your time. I know that you are not well, but still you are able to join us virtually. And thank a lot for taking us through the data and the case scenarios and enlightening the questions that were being addressed very significantly. Thanks a lot and wish you a speedy recovery, Professor.
Thank you. Take care. I hope that I have not deprived you from dinner. It's already perhaps 9 in your country. It's only 5:30 in Poland. So thanks very much for your kind invitation. Bye.
Thank you, Professor. And I would thank everyone who are present here and also Dr. Girish sir who joined virtually because he has some work and he was unable to travel here. So he wants to attend somehow and we could extend the invite to him to join virtually. And thanks a lot. And I really enjoyed your discussions and your questions that were raised today. And we would like to address any such questions or any such things which are left out. Please do reach out. We would like to address them and individually analyze the data as per required. Yeah. And Sachin.
Please join for dinner. Yes. Once daily dose 100 rupees, 5 mg 115 rupees, and 10 mg 130 rupees.